Okay, let's talk about EM, SJS, and TEN. This corresponds to Chapter 3, Section 3 of the Olicon textbook. So, what's the most common cause of erythema multiforme or EM? So, HSV is the most common cause. So, HSV-1 is more common, so more like the cold sore kind of herpes. Then HSV-2, mycoplasma, histoplasmosis, and then some drugs can cause it as well. What's the most common cause of erythema multiforme minor? So still HSV, and usually there's a cold sore 1 to 3 weeks before the EM. What's the most common cause of erythema multiforme major? So this one is actually mycoplasma with severe mucous membrane involvement. What other dermatologic conditions are seen in histoplasmosis-induced erythema multiforme? So basically, when you have EM caused by histoplasmosis, you can also see erythema nodosum, which would be painful nodules on the shins most commonly. What is the usual presentation of erythema multiforme? So first you get a lot of red macules that then become raised in papules and then they become target type lesions. So they look like a little target. And how do these typical target lesions present? So you have three zones. You have a dusky center, and then you have a pale edematous ring around it, and then you have an outer ring that's flat and red, and it's most commonly on the face and distal extremities. So dorsal hands and forearms are a very common location for it. How do the papular atypical target lesions present in EM? So these only have two zones, but they're palpable. And then if they're macular, like they're flat, it's more likely to be SJS or TEN. How can you distinguish erythema multiforme minor from major? So minor doesn't have much mucosal involvement or systemic symptoms, but major has severe mucosal involvement, and then you can have fevers, arthralgias. Most commonly, the buccal mucosa and the lips are involved, but it can also be ocular involvement, genital involvement. What are the histologic findings in erythema multiforme? So you have apoptotic keratinocytes at all levels of the epidermis with prominent vacuolar change at the basal cell layer. You can also see some spongiosis, some perivascular lymphohistiocytic infiltrate, but there's rare eosinophils versus there's more eosinophils in SJS/TEN. What lab can be useful in erythema multiforme? So 80% of people have detectable HSV on PCR. So even if they deny symptoms of herpes, sometimes it can be useful to do a swab from one of the erythematous papules or outer rims of targets just to see if HSV might be there and contributing to this, which can impact treatment, which we'll talk about in a minute. Well, now we'll talk about it. What's the treatment for erythema multiforme? So most of it's pretty symptomatic, but you can consider treating HSV and then HSV prophylaxis. It can speed up the course if it is caused by HSV, and then it can prevent this from occurring in the future. And then in very severe cases, you can consider systemic steroids or immunosuppressants. Who is more at risk for SJS/TEN? Shifting gears. So, elderly patients, HIV/AIDS patients, and slow acetylator genotypes, which has to do with that. It's mainly caused by drugs, medications. What HLA subtypes are associated with an increased risk for SJS or TEN? So, HLA-B 1502 is increased risk in Asian and East Indians, and that's with carbamazepine. HLA A3101 is also with carbamazepine, but in European populations. B5701 is with abacavir. And then B5801 is with Han Chinese patients exposed to allopurinol. And then last but not least, DQB10601 can be associated with ocular complications. What are the main mediators in SJS-TEN? So this is granulysin, which causes apoptosis, FAS-L, and granzyme B, and perforin. Okay, when does SJS/TEN start in relation to when you start the medication? So it's 5 to 28 days after starting it. It can be later with anticonvulsants, and drugs with longer half-lives are more likely to cause drug reactions. Okay, what serologic tests can be useful to distinguish SJS from morbilliform drug eruption? So you can do a granulysin test and high mobility group protein B1. These might not be available in every hospital, but just know that these are available and can help distinguish these. What is the FAS-L pathway? So this mediates apoptosis. So basically, FAS-L binds to CD95 on the target keratinocytes, and then it activates capsases, which leads to apoptosis. What drugs are most likely to cause SJS or TEN? So anticonvulsants are a big category for this. Also antibiotics, most commonly sulfonamides like Bactrim, also sulfasalazine, and then RTIs, allopurinol, lots of different ones. NSAIDs. What are other causes besides medications? So Mycoplasma pneumoniae, contrast medium, dengue virus, and CMV. What's the difference between SJS and TEN? So it has to do with body surface area. So SJS is less than 10%. SJS TEN overlap is 10 to 30%, and TEN is greater than 30%. And this is the not necessarily the body surface area involved with the rash, but it's the body surface area with epidermal detachment. So how does SJS/TEN classically present? So first you're gonna have fever, malaise, maybe a runny nose. Then you get these atypical targetoid macules. So like we talked about, these are gonna be flat, so it's different than the ones seen in EM. And they start on the trunk and then spread to the face, neck, proximal upper extremities. You can get some erythema, some pain. Then you get dusky plaques and you get full thickness necrosis, or full thickness sloughing of the skin. And then you almost always have mucosal involvement. So commonly oral, ocular, genital mucosa. You get photophobia. Sometimes there can be respiratory involvement as well. And then you get positive Nikolsky and Asbo-Hansen signs, which we're going to talk about too. So what is the Nikolsky sign? So basically, when you put tangential pressure, it induces a blister. How does the Ashbo-Hansen sign present? So when you put vertical pressure on a blister, it spreads into adjacent, previously unblistered skin. So Nikolsky is when you put tangential pressure and it causes a blister, versus Asbo-Hansen is you press down on an existing blister. What are the early histopath findings in SJS/TEN? So you get a few apoptotic keratinocytes scattered in all layers, and then a little bit of dermal infiltrate with eosinophils. What are later findings? So you get full thickness epidermal necrosis and a subepidermal blister. And then again, you have scant inflammation with eosinophils. What's the number one risk factor for mortality in SJS/TEN? So it's actually serum bicarb less than 20 millimoles per liter. So what are the score 10 criteria? So serum bicarb is one, but also age being over 40, associated malignancy, tachycardia, elevated serum BUN, an increased detached body surface area, and an increased serum glucose. So all of those get you points, and then the points correlate to the mortality rate. So you should calculate this on day 1 and day 3 of hospitalization in SJS/TEN patients. How could you prevent SJS or TN? So in East Asian populations, they should be screened for this HLA type before starting carbamazepine. And patients that are potentially receiving abacavir should be screened for this HLA type as well. What correlates with prognosis in SJS and TEN besides the score 10? So how fast you stop the drug. What is the most common complication of SJS and TEN? So it's eye problems. So it's really important to get ophtho on board for these patients because they can have long-term consequences, including blindness and scarring. What are other complications of SJS-TEN? So basically scarring at mucosal surfaces, hair loss, nail dystrophy. You can also get eruptive nevi in this, kind of similar to like the eruptive nevi in EB. How do you treat SJS or TEN? So, spoiler alert, there's no consensus on the best way to treat this, but you should do some gentle wound care. It's important not to remove the detached epidermis because it acts kind of as a biologic dressing. It's important to have nutritional and electrolyte support. Um, and it's good to get the appropriate teams on board. So, optho for eye involvement, urology or gynecology for GU involvement, pulmonology if there's any respiratory symptoms. And you should really go through the drug list and try to minimize as many drugs that could possibly be causing this as possible. And then there is some data for some systemic treatments. The ones that have the most data are systemic steroids, IVIG, cyclosporin, and etanercept. What is the mortality rate in SJS-TEN? So SJS less than 5%, TEN is 30%, but that could be a range. What's the most common cause of death? So it's usually infection, either with Staph aureus or Pseudomonas, but other causes could include fluid loss, electrolyte imbalance, insulin issues as well. And that is it. So we'll talk about other lichenoid and interface dermatitis soon.